get back on track for our last presentation. If you would please get a ticket. We have some nice door prizes that we want to give out. Also, after this last presentation, come to the art gallery for the packed dinner. All right. We are getting ready to introduce Dr. Diana Gins. She will be joining us virtually today. Dr. Gins is a licensed psychologist, board certified behavior analyst, and co-owner and chief operating officer of her practice, where she also serves as director of clinical training. She brings more than 18 years of experience working with individuals across the lifespan as a school psychologist, therapist, consultant, and university instructor. Dr. Gins completed her doctoral training and residency at the Kennedy Krieger Institute and Johns Hopkins School of Medicine, where she received specialized training in behavior disorders and family systems. Her work integrates acceptance and commitment therapy, cognitive behavioral therapy, motivational interviewing, and applied behavioral analysis to help clients live with purpose and alignment to their values. Dana had the pleasure of meeting Dr. Gins when she started her role as the executive director of the Florida Psych Association. During their conversation, Dr. Gins discussed topics that would not only benefit Florida, but could also help Oklahoma improve its method for measuring outcomes in our state. Please join me in welcoming Dr. Diana Gins for using measurement-based care to elevate clinical outcomes and navigate the shift to value-based reimbursement in private practice.
Okay, can you all hear me? Like, everyone kind of raise your hand if you can hear me. Oh, great, yay!
Yep.
Perfect. Okay, I can see this is so interesting, and I'm going to try to be as engaging and fun as possible from the perspective that I'm seeing everyone's backs and also trying to teach you all about measurement-based care. So, thank you so much for having me, and I'm so sorry I couldn't be there in person. But thank goodness for technology, right? So thank you for that wonderful introduction as well. I also recently started because only I love running businesses, I guess. I started another business with some colleagues where we are trying to elevate the type of continuing education that psychologists receive. So, as you guys will see in our next slide, our motto is serious training joyfully delivered. Today's presentation is going to be incredibly interactive. I'm going to do my best to facilitate that from here. And I'll have you all kind of in groups chat amongst each other and learn from each other along the way. So I don't know if you're anything like me, sometimes thinking about listening to an hour and a half about measurement-based care can make my eyes glaze over or can make me feel a little tired. Um, but like I said, I'm going to try to make sure everyone feels like they're walking away with some really practical things that you can use in practice, starting even as early as next week. I'm so excited to be here with you guys. So here is an AI generated, caught the end of the last presentation, so I don't know if this fits at all with it, but this is an AI generated image of myself and my two colleagues. We are this company Ascend. I think it's just the cutest drawing. I don't know. AI did a really good job with this, so I like to show it off when I can. Um, so this, I think you all have access to this in some capacity or another, but I wanted to put this up here. at the beginning. So if you have your laptops with you, you have your phones, you can download this. It's a tiny URL. It's a whole folder full of documents that you'll be able to take with you today when you go. And I have some very specific. Hopefully, I'll have time to get to them at the end. But I have some very specific handouts for Oklahoma. I was looking into your state's practices and how what I'm talking about fits within it. And so I put together a couple of things for you all. There's also something called a note catcher in there. So you don't have my exact slides, but you have the note catcher, which will give you all the information you need as you follow along today, and give you specific websites or prompts to visit as we go through this presentation. Okay. So I am not sponsored by any particular organization or company to come here and talk to you today. However, in the note catcher and in the end of the presentation, you're going to see a link, a QR code, and a link for Green Space, which is the specific measurement-based program that we use in our practice. So if you wanted to, if you're interested in it, you could download or you could access it via our referral code. Okay. So this picture represents how I want you to feel walking away from today's training about measurement based care. Um, and it's so happy and fun. So I hope you feel, yeah, I hope you feel so excited to engage in this process as we go through this and leave here today. So here's what we're going to cover. And then please know that I'm available for follow up and consultation after today's training if you want more support or you have any questions about the information you heard. Okay, I'm going to try to toggle between different slides with our next slide here. So this is a Mentimeter survey. So if you all could use your phones or visit that link um, and complete that survey. It's basically going to give me a lot of information about the room and where your level of comfort is in talking about measurement based care. So I'm going to give you a couple minutes to do that. Oh, yay, we've got some all hearts and rainbows. Lots of meh. Great. And I hope everyone's getting the image of Kevin in Home Alone where he's looking in the mirror and like, "Ah!" Right? Like, hands on the side of his face, like, in pain. Okay. Wow, it's a really divided room. We've got a lot of meh, some hearts and rainbows, some Kevin in Home Alone, a lot of something else. Okay. Well, thank you all for letting me know how you feel heading into this. Like if I had it my way at the end, I should do this survey again and come back to it and see if everyone's all hearts and rainbows at the end. That would be such a great way to measure my success as a presenter. Um, but let me get back to my okay. So here's some learning objectives. So I want you all to be able to describe the core principles and empirical support for measurement-based care and how integration enhances clinical outcomes and strengthens therapeutic alliance in psychological services. I also want you to understand the use of standardized outcome measures to better understand and tailor interventions to clients' unique values and experiences. Okay, so we're going to do something. You all in your handouts in the note catcher, or you can look at the screen up here. They're the same thing. There's a website for where you can visit the Who Five. You can see the Who 5. I don't know, visiting it, seems like a weird thing to say, but you can see the Who 5, or like I said, you can look at it up here. And what I want you guys all to do is take a minute and rate yourself. So take a moment to jot down what rate yourself in terms of how you are right now today. Um, and by today, I mean over the last 2 weeks. So, this is a classic rating scale that we use. So over the last 2 weeks, you fill out 1 to 5, 5 and rate it on a scale from 0 to 5. So I felt cheerful and good spirits. 5 is all the time, 0 is at no time. So go ahead and rate yourself how you've been feeling over the past 2 weeks. Okay, so I want you to take a minute and jot down some thoughts about your ratings. And specifically, if you were heading into a therapy session right now as the client, what would you want your therapist to know about your ratings? And how is that different than maybe what you thought you would come in with? And since you all are in nice little table groups already, maybe just share a couple of thoughts with your table about what you thought about this. All right, everyone. I can hear people when they're talking on the microphone, but I can't hear you all otherwise. So think I'm thinking that's enough time. And I'm not quite sure how, if anyone has questions, how to um go about that, but maybe you all can let me know what might work best for you. Um, but I'm just gonna move on from that little activity. So the next part of this is are you walking to grab the microphone? Thank you.
Yes. Does anybody have any questions for her at the moment? I don't think there's any questions at the moment.
Okay, great, thank you. Um, okay, so um the other piece of this is not just how you're feeling today or how you feel about measurement based care, but what matters to you. So I know you all have been sitting all day, and well, a lot of you have been sitting all day, and this is the end of the day. And I'm grateful that you all are here at my presentation. And I'm just curious about sort of like what's meaningful to you all about learning about measurement based care. So, how does it fit within your practice or your values system as a psychologist? So I have this picture up here because this is my Ascend team. And one of the things that we value is data. So, as tedious and hard as that makes things sometimes, I always come back to this idea. I mean, as many of us are, I mean, I um, am a researcher at heart. And so I really value collecting and measuring outcomes. And so, as do my team members. And so I come back to this sometimes when I feel like it's overwhelming or I have too much data and why am I doing this? It's an expensive program and it feels overwhelming, but really at the end of the day why I'm doing it is because this kind of information is really important to me and my practice. So maybe spend a second just chatting with each other or jotting down a couple of lines about why this might be important to you, um, and what drew you here today and what do you want to get out of this presentation. All right. So moving on. Measurement-based care is called lots of different things in the literature, or in practice even. And so, simply put, it's the process of using client-reported outcome measures, and we use them repeatedly, routinely, and with intention. Um, it's also called all these other terms that we have listed here, and also um, in your handout as well. So if you see any of these other terms, it's just referring to what I'm talking about today as measurement based care. So if you've ever stepped on a bathroom scale, you've used a routine outcome measure. One weigh in doesn't tell you much, but checking your weight over time helps you see patterns, track changes, and decide if your current actions are moving you where you want to go. So the same goes for client feedback. Um, a single data point isn't the goal. It's the consistent intentional tracking that helps both you and your clients see where things are shifting and what might need to shift next. So we have a couple of different types of measures that we use. So the system that we use, like I was mentioning before, is green space. We used something called Blueprint before. A lot of EHR systems now have built-in um, measurement-based care measures that you can send out. And I can we use Sessions Health. I'm not sure what other folks use, and they also have measures within it, but we chose GreenSpace because it gives us a really robust way of looking at the data, and I'll show you a little bit later what that looks like. But within that, we mostly think of measurement-based care as things like the PHQ-9 or the GAD-7. But GreenSpace has something like 600 measures available. So it's quite comprehensive. And so I feel like new measures are being developed all the time and are getting really niche and specific to certain types of therapy processes. So like my framework for the most part is acceptance and commitment therapy. And I feel like there's so many measures that I can send out related specifically to the processes of ACT, which is cool because I'm teaching, teaching ACT. I'm using ACT in session, and then I want to see how is that impacting outcomes. So there's like the five facet mindfulness scale. There's the psychological flexibility scale. There's lots of different things I can send out to see like how is that translating to what the client knows and understands. But again, we don't just have to look at things like things that are come pre-created, like the PHQ-9. We can use more idiographic or individualized measures. So these are things that are specific to the individual, like goal attainment scaling, that or a rating from 1 to 5 on I don't know how they did turning in their. I work with adolescents, so turning in their homework each day of the week, right? So we can be very specific to what the client wants to work on, as well as using more commonly used measures like the PHQ-9 or GAD-7. Let's see. So let's talk about the benefits of using it. I'm going to give you like lots of numbers now. Again, a lot of these are in your note catcher handout. But when the core idea here is when we track client outcomes over time and use that data in session, clients get better. So we have some research here that indicates that in different studies compared to control groups, clients were 3.5 times more likely to improve, 40% less likely to drop out, and had significantly better long-term outcomes. This is data from GreenSpace. I feel like I work for them because I've been mentioning them so much, but I don't actually work for them. But these data it's from their system. So it reflects average outcomes across hundreds of organizations across the US and Canada that use the GreenSpace measurement-based care platform. And the trends are clear. When it's implemented consistently, clients report stronger therapeutic relationships, higher assessment completion, and greater progress in treatment. So the last kind of numbers slide, I call these, that I'm going to go through with you. I'm going to tell you about 2 different studies, and then I'm going to have you all talk with each other. So in 2005, Hannon et al. Took 48 therapists at a college counseling center, and they were asked to predict which clients would improve or deteriorate after the therapists themselves were blinded to weeks of OQ45 data. OQ45 is like a general outcome measure. So OQ45 data from 550 clients. So they asked these therapists, do you think your clients are doing better, worse, or the same? And the outcome was that of the 40 clients who actually deteriorated based on this measure, the therapist only predicted that 3 might have deteriorated. So 40 clients deteriorated, and therapists only identified that 3 might have deteriorated. So they missed a lot of clients. If they were just going off of their clinical judgment alone, they missed a lot of clients who actually deteriorated. Um, these same therapists predicted improvement for over 91% of clients, but only 40% of clients actually improved. So um they really over predicted how well their clients were doing. um and the too long didn't read is that the majority of clients showed no change, and therapist predictions were largely wishful thinking. So that's kind of the first study I want to talk about. The second study is Walfish et al. 2012. Um, 129 mental health clinicians in private practice were asked to self-rate their clinical skills. So this one is specifically related to a therapeutic alliance measure that we have a lot of clients complete, that's looking at, is my therapist meeting my needs? Do I feel respected by my therapist? Do I feel like we're collaborating on goals? Do I feel like I'm actually making improvements based on, the work I'm doing with my therapist? So a therapeutic alliance rating is what this study was looking at specifically. And out of the 129 mental health clinicians in private practice, the average rating that these therapists gave themselves were that they were at the 80th percentile. So every single one of them indicated that they were above average as therapists. And not a single respondent rated themselves below average. 93% of them placed themselves above the 50th percentile. So, you know, that's obviously a mathematical impossibility that we're all sort of above average clinicians, but the idea of collecting therapeutic alliance data is to get better as a clinician. So I'll have a specific example I'll walk you all through a little bit later. But I just gave you all a lot of numbers and information, and I wanted to give you all a chance to. So this is my slide that indicates we're standing up and stretching. We are not going to do this. Although I think it would be really fun for me to watch you all from here try to do that. But I want you all to just actually physically, if you can, if you're able, stand up, because we got to get some blood flowing so we can chat with each other. And do some gentle stretching while you share at least one key takeaway from the number slides that I just presented. So any of the ones that we're talking about, the studies or the improvements. Okay. I would love to hear some, if it's possible. I don't know if we can do this with the microphone, but I would love to hear anyone's takeaways thus far, thoughts, reactions. Um, are we able to have the microphone passed around, or does anyone want to volunteer to share?
Do we have any sharers? Anybody? Well, my table decided we're in the top 8. We're the above average.
Me too, me too. All right. No one wants to give any thoughts? Sum it up for the room? All right. Well, I will move on. So we obviously know that measurement-based care, all the things we just talked about for the last 10 minutes were about how great it is and how important it is and how wonderful it is and how
Diana, we were gonna
oh, yep.
share our table.
Yeah, go ahead.
Okay. One of the things that we talked about was we'd love to do more of, we want to know if we're effective in our work.
Yeah.
But we're a small operation. And so if we had, or if we had something that we could send out to clients in our EHR, or we use therapyappointment.com, and
Mm,
where if we could just send it, and know that our clients wouldn't feel like they had to report
mm.
um, a positive impression of us since they're using us, but where that would be more reliable. And so, but we want to know if we're being effective. How do we disseminate that to our clients um, with great dignity and respect for them?
Yeah. That is such a good question, and it's almost like you're in on this presentation because you just like you just presented a great segue. Um, so thank you. We're gonna talk about all the ways to actually use this. So I appreciate that. And I know there's a barrier to getting started, and we're gonna talk about it. Um, okay. So so yeah, so it's so great, we should all use it, and, like, fewer than 20% of practitioners are using measurement-based care. That's, like, a dismally low number, right? Um, and, one of the things that we're gonna reference a little bit later is, the APA came out with, in earlier in this year, in February 2025, they came out with their clinical practice guidelines for measurement-based care. And I think, and this is kind of what I'm going to end the talk with today, I think that many of us will be, if we take insurance, right? If we're an insurance-based practice, I think that many of us will be sort of forced at some point to be doing this because insurance companies, I think we're seeing a lot more EHR systems showing up with measures. And I think there's a lot of emphasis being placed on people collecting data. And I don't know about you all, but I want to be on the front end of this conversation rather than the back end of this conversation. So if we're going to be forced to collect data, I want to be doing the things now so I can help guide practices as they roll them out, as opposed to be having to do things that I don't agree with or I don't think are right. So part of the impetus for me is not just that this is good care, but also that like I want to do the things that they're like I want to be ahead of the game. Um so So there are lots of barriers, and I'm sure if I was going to have you do another Mentimeter, but I'm gonna skip it, so don't do this one because I'll just summarize what other people have said. Like, what are the barriers? So I'm sure you have a bunch in your head already, right? Limited time. Maybe it's too expensive. You're nervous about they're gonna rupture any sort of therapeutic alliance. It might be unhelpful at times. Insurance doesn't pay for it. There might be a burden on the client. So there's tons of reasons why people are not engaging in this. But what I hope to do is see if we can work together to make some of these barriers disappear and make using measurement-based care our clinical superpower. Okay. So just by like a show of hands, how many of you all are in private practices? Okay. So are the other folks with like bigger organizations, hospital settings? Do you have a sense for like people who work in systems, like say for the VA, who don't have a choice over what kinds of things you do?
We do have some integrated care hospitals. Some folks work with tribal organizations, things like that too.
Mm-hmm. Okay. Um, So I will not lie, adding measurement-based care does add um a couple more minutes of work for each client for each session. I will say that. I know for me, I see folks on the hour and I have, 7 minutes between sessions and it's pretty sacred. So I understand any sort of concern about like, oh, can I give up a minute or two? And what I do for my day is when I get there in the morning, I pull up all the data for the clients I'm going to see for that day. And so I have it all preloaded. So I don't even have to really between sessions I will have looked at it in the very beginning of the day to see where my clients are at. And then usually how sessions work with me is like, unless they come in a crisis or there's something more pressing, we do start with any sort of change in their reporting of symptoms based on their measures that they completed. So I will pull it up and then we talk about it together as the session starts. Um, so um, I'm going to go through these 4 different areas um, and just talk about what it looks like for each of these areas if you're using measurement-based care. Um, so for onboarding and intake, just to give you some context, we at our practice we have practicum students and a couple of postdocs, but licensed clinicians, we have 9 licensed clinicians and 15 clinicians working overall if we count our students and postdocs. Um, so um, so we have a director of measurement-based care who helps train all new clinicians on our processes around this and gives feedback and meets to do like data review with folks over time as they collect data as the clients that they're working with are filling out measures. But at onboarding and intake, we start by indicating we use measurement-based care. So during the first session, we start talking about it. Actually, our onboarding coordinator, our intake coordinator, sends out a before the first session even. So we usually do a baseline PHQ-9 and GAD-7, even though that's not always what's clinically indicated in the long run. It gives us a good starting point. So clients will have gotten a measure before their first session. And then we talk about it in their first session. So we talk about how we use it. They will automatically get whatever measure we're using. They'll automatically receive it either every other week or once a month, depending on what we agree upon in our therapy sessions. So we talk about it collaboratively, and we talk about why we're doing it, and we talk about what we're hoping to see. And everything we do, we wrap in collaboration with the client. So we start that from session 1. So within session, like I said, I open my sessions with reviewing the most recent data if they've completed something. So hey, like, let's take a look at what you filled out since the last time we saw each other. And I'll ask about it. The system we use graphs the results. And so we can see, are things getting better? Are they getting worse? Are they staying same? What's going on? What's the context for that? And it sparks a conversation. And just like the Who 5 that I had you all kind of fill out in the beginning, sometimes it is different. It creates a different environment for session that day than would have otherwise been present. So sometimes clients will fill it out the day before, let's say, and they'll come in and they'll be like, I don't really have anything to talk about. I was like, whoa, wow, like you filled this out yesterday, and yesterday you had a lot to talk about. Like, here's what you rated yourself that, on this scale. And they will be like, oh, I forgot. Like, it's just yesterday. So, it's helpful to have that tool. So, the next thing is between sessions. So most systems will allow you to automate a little bit. So like you can set, a week, um, how often you want the frequency that you want these things sent out. And then collaborating with them on like what works best for you. And our system allows us to do it via text or email. So it's like, which would you prefer? Yeah, when do you want it? That sort of thing. So we try to collaborate with them on how to engage best. And then in terms of documentation, we have our within our notes. So our system creates a little snippet that we can put into the session note. So I will talk a little bit more about this, but we bill insurance. We use 96146 as an add-on to each session in which we collect data and we discuss the data in session. So it is a minimal amount of revenue. Like it's depending on the insurance company. For us, it's like between $3 to $10 a session, but it is enough to offset the costs of us using the platform that we use. So it's not like a profit maker for us, but it does pay for our system. So the 96146 code is like single automated test with automatic results, computerized or something. I can't remember the exact language, but that's what we use. And so we make sure to have the snippet in the notes so that we can justify the 96146 code that we bill for that session. Okay. So let's take a look at how feedback actually functions in the therapy room. So in the upper right, we have, oops, in the upper right, we have the client's experience. When they complete a measure and see their responses reflected visually, it can be surprisingly validating in my experience. So, um, one client puts it like this. One client I worked with puts it like this. So, with the graphics, you, my therapist, can now see what I think and feel. Um, so it can create this moment of being seen. So in the bottom third, so down below where we have what the clinician notices. So this is where you, as a clinician, might start noticing there's a dip, a sudden shift, or even a lack of response to completing the measure. So, and when this happens, like it's not about scoring, it's about curiosity. So, what I notice in the data, whether it's up, down, or sort of a lack of response, it drives what I ask in session. So it sharpens our clinical radar. Okay, so now going around the circle to the upper left, this is where we act. We bring the feedback into the conversation. Maybe we adjust our treatment plan, or maybe we might bring this. I have a lot of supervisees, so they bring this into supervision with them. Or maybe it even makes us reconsider our case conceptualization. So the arrows support the idea that it's not one and done, it's a loop. It's a breathing process of engagement, insight, and action. This mechanism of action is actually taken from, Jensen Doss et al. This is the primary study that drove the APA guidelines that came out earlier this year. All right. So collaboration. Um, so here's a fun metaphor, I think. So these are two pilots, right? And both pilots are invested in a safe, purposeful journey. The data is mutual, and so are the decisions. Um, so just like a pilot and a co-pilot, right? You and your client are kind of checking before adjusting course, right? You are checking in, you're looking at the data, you're trying to understand where they're coming from. And when we treat outcome data as a shared tool, clients feel seen, um, and therapists stay curious. Um, so I'm going to have you all do a little activity together. Instead of hearing me talk more about this, I want you to visit the APA. I think it's in your note catcher. It's apaservices.org, and then it's the measurement based care specific link. If you have access to that, it would be great to pull that up. Um, And I want one of you to, if you're in a group, one or a couple of you pick the administration piece, one or a couple of you pick feedback, and one or a couple of you pick integration, and jot down what you see in that guide that informs each of those. Here's the code or the QR code or the link in case people need the access to the document. Okay, so I'm gonna bring us all back. And I hope that some of this is sort of answering or responding to the previous question about how to do this and like when you're in a small practice, like how do you make this work? And when I'm you have now you have the document, you can come back to it, but just some kind of like cheat sheet kind of points. For administration, I wanna say, like, we do it with clients, not to them, right? So, like, when my client is completing a therapeutic alliance or a PHQ-9 or whatever they're completing, um, it's it's like, how are we doing? Not like and it's a collaboration. So, um that's how I get buy-in, right? And then collaborating on timing for administration is really helpful. So, like sometimes I want to send something every 2 weeks and someone's like, "You know what? That feels like a lot." So, can we do it every 4 weeks? Totally. Yeah. It's not there's nothing set in stone of like how much we have or how often we have to send it out. Um, so in terms of feedback, I often talk about um the numbers as indicators of how much that symptom is in affecting them within a certain diagnostic category. And I will say here that not all measures are symptom measures. Some are quality of life measures. So some are about any actions, in ACT, we talk about committed action. So what sort of committed actions are they taking this week? Did they feel like they were able to accomplish them? So it's not always about symptom reduction, it's about quality of life improvement. Um, in terms of integration, um, I'll speak mostly about Therapeutic Alliance here, and I'm about to jump into a case presentation about one of my clients. And I do this because my Therapeutic Alliance with this client was not high. And it actually taught me so much about what this client needed. I thought I was, such a great therapist, and then this client was like, "You're not doing what I need you to do." And so I'm about to talk about that now. So um moving on, this is data. These are data from one of my clients. This is when we were using Blueprint before, so it would graph it. And so you have sort of different measures that you can see the client's outcome. So we are using the CFQ-7, which is an ACT measure. It's for cognitive fusion. The WHO-5, which is a well-being measure, overall well-being, that you guys completed at the beginning. And then the WAI is the Therapeutic Alliance measure. And I'm going to show you specific questions from it in the next couple of slides. So you can see where he was rating me low. And then the GAD-7. So how his initial presentation, he came in with incredibly high anxiety. And so you don't see the beginning of this data. So it would be more like a parabola, but I don't know why we're not able to see the very beginning of his data, but it was basically high at the beginning and then high at the end, which is the data point that I was like, well, we need to talk about Therapeutic Alliance. So his anxiety shot up as his Therapeutic Alliance was going down. So how he felt about me was getting worse as his anxiety was intensifying. So Peter was my client a couple of years ago. And by looking at his GAD-7 scores, I was able to see where his anxiety was becoming much more problematic. Even though we had worked on skills and strategies related to anxiety, the difficulties remained and in fact were worsening. So I started looking into my scores from our Therapeutic Alliance questionnaire. He was completing this every 4 weeks. So the WAI is a 16 um 16 item measure that has 8 questions on bonds. So how much are you bonding with your therapist, and 8 questions on tasks and goals. Oh, I don't know what happened to the slide. Let's see. I thought I had information for you to look at. Let me see. Nope. I don't know what happened to it, you guys. I'm so sorry. But what I will tell you is that oh, I know why, because you can see it on your note catcher. It's on there. So you can actually see the areas that he rated me low. So you can see also how his score changed over time. So a couple things stood out to me as I was looking at it. He initially thought we were collaborating on goals of therapy, but he was clearly not feeling that way anymore. And he did not think we were on the same page about how to work with his problem. So here's what I did. I asked him why these scores were lower now than they were before and how we could change things in session to be more helpful. He said that he wanted more concrete things to do in between sessions that were related to improving communication with his partner, which is where a lot of his anxiety was coming from. And I'll be honest with you, before this conversation, I had no idea that that was even an issue. Like he had not brought up any sort of conflict about conversations with his partner, and I had been seeing him for like 5 months at this point. So, um, we made sure to spend the last 5 to 10 minutes of each session summarizing what we had talked about and collaborating on how he could translate that into something he could talk to his partner about that week. And it worked. And he was so thankful that I was so invested to even ask him like why he was rating things the way he was. I don't know about you all, but I have to fill out the PHQ-9 and the GAD-7 every time I go to the doctor, and like no one ever mentions anything to me from those times I have to fill things out. And so I don't know if that's people's experiences or what, but I think it only strengthened our therapeutic alliance and like really turned a corner for us. And I think he is someone who would have discharged had I not done that. So all that to say, like that was a really good experience, but it was really scary to get a low therapeutic alliance rating. Like I thought that was a terrible feeling as a therapist. Okay. This is a this is a picture of a um llama or alpaca, I can never remember, from a trip I went on last year to Peru, and it's in here just because it's really cute, and I think, like, I just dropped a lot of information on you, and it's just a reminder to just, ground yourself and take a breath in this moment. Um, don't go too far in your head because we have a lot more work to do here, but just wanted to give you all a second to just sort of refocus, recommit. Okay. I am going to spend a little bit of time talking about value-based care. Is by show of hands in the room, are you all familiar with this term? Is this a term that people know about? Okay. The area of the room that I'm seeing, there are no hands raised. So I am assuming that maybe that's representative of the rest of the room as well. Um, okay. So buckle in. I did give you a second to breathe looking at a llama or alpaca. Um, so hopefully you are all ready for this next part. Um, all right, value-based care. So this is a healthcare model where providers are reimbursed based on patient outcomes. So here's what's going on. And I am on a number of committees across different states where we talk about this. And in Florida, where I am, it's on the horizon. Um, we are not a managed care state like you all are. And so I think you actually might see this a little more quickly than we do. Um, so I'm sure the wheels are turning as you think about, okay, what does that mean? Reimbursement based on patient outcomes, right? Because then I don't know if you're like me, when I first heard this, I started panicking. Um, so it sounds so great, like value-based care, like, yeah, of course, like I want to do that, sign me up. But the problem is, at least the way that we're talking about it now, is like we're not assigning the value, the insurance companies are. So, and when we give them that authority or when they take that authority, it usually means they're going to do something that's not always patient friendly, right? So, um, the term value-based care, it gained momentum in the early 2000s. It is a response to rising costs and inconsistent care quality under fee for service. It is widely used in medicine, and medical practices use it regularly now. So hospitals have to report benchmarks. Um, doctors have to report benchmarks. They have very specific outcome measures they have to assign to interactions with you as a patient. And it is related to bundled payments and outcome-based contracts. So mental health, behavioral health, mental health is next. And so there's a big movement, and again, different states are experiencing it differently now, but where insurers are applying values-based care to behavioral health. So that means measurement-based care, outcome tracking, and insurance definition of what value is. Um, so um, I mentioned before that measurement-based care is showing up everywhere now. So it's on EHR systems, it's being talked about. APA put out a policy statement on it. All these different systems are popping up that are like adjunct measure, creating adjunct programs that you can buy and use, like the ones that we do. So it's not a coincidence that this is all, there's a momentum in this direction, right? Like someone is talking to someone at a high level and knows that this is being rolled out and they're trying to also get ahead of it. So, so how does measurement-based care fold into this? Well, again, it's focusing on patient outcomes, right? So it is okay, you provided 6 therapy sessions. How is their anxiety symptomology? How are they faring given your treatment that you're providing? Right? So it is going to be looking at and we all know as psychologists, like life is messy, right? It's not linear. Like you can't just say, oh, well, they had 6 sessions. And so we can see X amount of improvement. And that's going to continue to grow as we move forward. Like we're going to see ups and downs. I think that we need to be on the forefront of this conversation because we can say things like this, right? Like we can say what is reasonable in terms of them being in therapy and what are we hoping to see overall and how many sessions would we need to see that, right? So it's not just like, well, they did dip at session 6 and session 8, but we know that that's, life circumstances. So we want to be part of that conversation ahead of time. So I mentioned this before, insurance companies may define value. Yeah, so they may start tying reimbursement to certain metrics we don't always control, like symptom reduction timelines or number of sessions. This could subtly or not so subtly nudge clinicians towards narrower practices, faster treatment pacing, or increased documentation pressure. So for group practices or solo clinicians who are trying to get or stay paneled, this shift is already underway. So practices may face stricter criteria to demonstrate quote unquote effectiveness. Think outcome dashboards, quality metrics, even client satisfaction scores. And reimbursement rates could increasingly align with value-based metrics, not just credentialing or service volume. Okay, so in that, and I can go back to the QR code, but in that handout, in the folder gave you all, I just wanted to draw your attention to a couple of documents. There's one that is VBC resources in Oklahoma, values-based care resources in Oklahoma, and there's one that is overview of the VBC model in Oklahoma. So I'm going to just draw your attention to the bottom of, let's see, the bottom of page 1, top of page 2. It just states like if you're a behavioral health outpatient practice in Oklahoma, you should begin preparing. evaluate whether you serve the target population, so adult Medicaid, Medicare with moderate to severe mental health or substance use disorder, and then look at what systems you're using. And are you ready to report things? And I hate to be like, I hope this, I don't know. I don't want to be like, I don't know what the word is, but it feels very scary sometimes to think about all this. But again, I wanted to provide you with this all now so we can be, in this kind of safe environment to talk about some of these things before they actually roll out. So you have those resources to look through on your own. I want to tell you also that we just went through a round of insurance renegotiations. And I'm going to try to toggle to my screen where I show you our green space data. Let me see. I don't think this will give you, let's see if I can do this without messing too much up. So I'm going to stop sharing this. Oh, wow, there I am, really big. And I'm going to share my dashboard with you. Okay. So, this is my dashboard for the for green space, and it's quite comprehensive and gives us a lot of information about how our clients are doing. I can I can look at measures by all the things that we've given. So these are all the measures that are available to us. And I can look at um, how many people have responded, and I can see the average scores over time. So, yeah, it gives us, like I said, a lot of data about our clients. Um, we were just discussing this today, actually, this 15% average score improvement. And that's looking at all the measures we send out. And we reported that number to the insurance companies when we just did our renegotiation. And I don't know if that's good or bad. I don't know what the data suggests we should be. Um, I don't know. I mean, 15% sounds good to me, but I don't know. Our average therapeutic alliance as a clinic is 89%. Um, and then here's just more information. Yeah. So I'm going to try to go back to my PowerPoint. So, like I said, we send in quite a lot of comprehensive data about our outcomes, and we got some pretty great rate rate increases. So, um, at least for now, that's how it's serving us. And we're just sort of bracing for what is to come. We think that at least the PHQ-9 and GAD-7 are going to be um, heavily encouraged as measures in the next couple of years from insurance companies. And so, like I said, we're just getting ahead of the curve as we do this. I want to leave let's see, a little bit of time to see if there are any questions or discussions that you all um, want to chat about.
Diana, how do you measure your therapeutic alliance?
So we have um there's a form. So the WAI, the one that is referenced in the case study, that was the one that we were using previously. The one we're using now is it's just what that was what Blueprint used, what their therapeutic alliance measure came with. The one now in Green Space is that came with it, I'm blanking on it, but the one that we asked them to add was something called the CalPAS. It's the California Alliance. I'm gonna look it up. I can never remember what it stands for. Therapeutic Alliance, CalPAS Therapeutic Alliance. It's the California Psychotherapy Alliance scale. Um, and I really like that measure. I think it's really helpful for clients to think about, am I collaborating with my therapist in a way where they understand my needs and what's going on, and are they working with me to get me where I want to go?
Hi, thank you for your presentation. Can you tell us
Yeah.
what testing codes you're billing? And are you billing them on the same date as the therapy session? And have you been audited and how did that go?
Um, yes, I can tell you. So we're billing 96146. There's a couple, I don't know why our system does it this way, but we're using it as an add-on. So it's 96146 as an add-on to a therapy session. So not just a 96146 as itself independently. So we bill it, we do for a session, we will have the session service code, so like a 90837, and then we have the 96146 as the add-on code to that session. And we have been audited and we are great. No one has had any issue with us using that code. And like I said, I think I said this before, but it's like depending on the insurance company, it's like so we have a couple things going on with that. It's anywhere from $3 to $10 per code per time every time we use that code. Um, we have had some issues. We have a couple of master's level therapists, and for some reason, the insurance companies, one of them won't pay for the master's level therapist to use those codes. So a couple things like that have come up. I'm trying to think of anything else that's relevant. But yeah, as long as we're putting that blurb in the SOAP note that we create for that encounter, um, about the outcome or the outcome of the measure and a comment about that we discussed it in session, there's been no issues.
Quick follow-up. Do
Mhm.
you have to include a modifier?
Nope. We have not had any issues with that. And I should look more into this, just as an aside, someone was telling me that they use another code that's more akin to like a psychological assessment code, and I haven't gone into that territory yet. So it makes me nervous. So I don't know. That's what we've been doing and we've been fine.
Hello? Okay.
Yeah.
Thank you for your time. When I think of a measure-based care, the first thing that pops into mind is like manualized therapies because they have,
Mm.
weekly measures, monthly measures, every 10 sessions, whatever it is. I appreciate the flexibility in meeting your clients and how they can fill these out. Is there any guidance or research, though, of how often or how frequently we should be using these if we do?
Yeah, that's a great question. So, that APA document, is going to give you a lot of helpful information of guidelines. In terms of research, I think that, the research studies that are using measurement-based care are not necessarily to look at the frequency of delivery of measures, it's more to look at the outcomes. And so I think it's tricky because we've definitely sat as a leadership team and tried to decipher what do we do based on what's out there. And I think our answer right now, unless we're told differently, is using our best judgment and collaborating with the client. We have one therapist who wants to send measures every week, and we're like, no, we don't. We're gonna overwhelm people. I don't. That's just not. So, I'm like I said, like a every other week or every 4 weeks kind of thing.
Any other questions? Dr. Gens?
So before you all leave, I would love if you all could do an evaluation. So this is a link to
Hello, I have
our
one more question.
oh yeah, sorry, go ahead.
Oh, thank you. Um, do you utilize this with children or is this only with adults right now at your practice?
That's such a good question and thank you for asking that. Yes, we absolutely use it with children and we have child-based measures and we have parent measures as well. So um we co-assess, like we look at what the child is saying versus what the parent is saying and then that gives us a lot of information for our parent sessions as well when we have them. So we often, as you can imagine, see a difference between the way the parent is seeing things and the way the child is. And so all of these measures come in, I wouldn't say all of them, sorry. A lot of the measures come in child or adolescent versions themselves.
Do you also
So
share parent report with the children or is that situationally based?
it's situationally based, and sometimes we will. Sometimes that's very helpful too. But that's a great question because I think sometimes parents are misinterpreting things that kids are doing, or um, they might see things in a completely different light, and so it can be helpful for the child to understand sort of how the parent is seeing things as well. Absolutely.
Thank you.
Yeah. So I'm going to leave this up here as I say goodbye to you all. And this is also in the note catcher. And um, if you don't mind filling out the evaluation, it's very helpful for me to understand what worked for you and what didn't work for you with this presentation, what you liked, what you didn't like. I love feedback at this point. So I'm grateful to have been here with you all today, and hopefully I'll meet you all at some point. Oh, thank you guys. I can't hear it, but I can see it. Appreciate it.
All right, let's see who the lucky winner is. 7872665. Going once, going twice. All right, we're gonna pick an. Oh, okay. Congratulations, you won. All right. So I want to thank you all. I know this was a very full day and you all are still standing, well, actually sitting. So you all would get a gold star if I had any to hand out. So just know that, draw your own gold star on your paper. But we hope that you can hang in there for just a little bit longer. We're not quite done. We are going to have our dinner right after this. It's going to be in the art gallery. That's an opportunity for you to network. We're going to have entertainment. It's also an opportunity to donate towards our PAC, which, for us to have a seat at the table means we have to have some money. And so there's an opportunity to help us that helps us educate our legislators, that helps us elevate psychology in the state. There's a QR code if you don't want to go to the dinner, but you still want to donate, so that you can donate that way. And then if you, I told you about the Bedlam Challenge, so you can also donate that way. You can fill out a contributor form. That is for our Ethics Commission. So, we can document all our donations. And then if you really want like 2 gold stars, after the dinner, you will go to one of the division meetings. So we're going to have, I know this is like a really jam-packed day that just keeps on going. But we'll have 2 division meetings. I believe it's HSP and DRAT. And then we will start super duper early in the morning for the diversity and the RXP meeting. So yeah, please come over and join us and let's have some fun. And you will get CEUs for your attendance. So double win. Yeah, please come. Thank you.